Back, everyone. Hour 2 of Middays is live on the air from the Element Well studio. We welcome now to the studio. It's Dr. Dan Edney, State Health Officer with the Mississippi State Department of Health. Dr. Edney, good to have you in today, sir. Thanks for coming on.
Oh, thank you. Always glad to be with you.
So we've got a rather active session down at the Capitol is one way to describe it this year. And, of course, the Department of Health, being such an all-encompassing and rather broad organization, I mean, serving every corner of the state, honestly, and touching every Mississippian. It's
every day.
Every day, right. Mm-hmm. So we're seeing lots of legislation that could impact your funding, your operations, the services that are provided, the organizational structure, policy, all the above, really. And I don't see how you keep up with it. I know you got a great team that helps you out with that quite a bit, but what are some of the things that particularly got your attention that you're dealing with right now?
Well, and of course, we'll see after the deadline today what's still alive. There are several things that got my attention that do not appear to be gaining traction. So, focusing on the areas that are, I'm, very pleased in the support from legislative leadership and what we're doing and our mission and supporting us and achieving the mission. Everybody understands the importance of the health department and not just for running county health departments, which is a critical issue and service that we do, but in keeping everybody safe through food protection, water safety, regulating and licensing hospitals, nursing homes, assisted livings, daycares. I mean, I can just go on and on and on. Mm-hmm. And so one thing I'm always watching is are there any new assignments coming our way? And, like the cannabis program was a major assignment. There may be another assignment coming related to intoxicating hemp. We'll see.
Okay.
And that kind of stuff. They'll ask us, can you handle this? What do you think? And, I don't try to say, that's a really bad idea. You don't need to do it. I'll say, well, if in your wisdom you choose to do this program, we can handle it. And just as long as you fund it.
Yeah.
But unfunded mandates are definitely a thing.
Yeah.
But this year, our focus has been maintaining the authority of the Board of Health and the state health officer and the health department in terms of keeping everybody safe and doing the job that we have to do. Everybody is reviewed every 3 to 4 years, and this was our year, and I've been very pleased with the response that we've had. We're looking at how what we need to do things better, because we have a lot of opportunity to do things better at the health department that I recognize. And one way is through community health workers, which are extremely important members of the public health workforce that haven't really been recognized in Mississippi yet, but have in many other states. And these are workers that are lower income, often entry level, that we train and certify, and they're able to go out into the community to work with our highest risk patients to navigate them through the system to make sure they're getting what they're supposed to get to improve outcomes. And 20 years of data shows pretty clearly that they reduce cost and improve outcomes, which we need both of those things at the health department.
Yeah.
And a lot of other things that are coming our way, but, nothing that's really earth-shattering so far.
Okay. Well, I testified a couple of weeks ago. I think I shared that with you. I was asked by Representative Sam Creekmore, who serves as the chairman of the Public Health Committee in the House, and this was a joint meeting, a joint hearing, if you will, of public health and Medicaid from both the House and Senate. And I started out by saying, you really have to sort of frame this issue across really two areas. There's health, and then there's health care.
Correct.
And they're two different things. And the Department of Health, of course, is focused on both. But I know you personally take it as your mission and your passion is the health of the state's population.
Right.
And you pay a lot of attention to that. You track that. You speak about it, you write about it, and I know you talk to members of the legislature and elected officials about it all the time. And this is an area where we have opportunity for improvement.
Oh, absolutely. And I mean, if you really don't care about the health of our individual members of our communities and the population, then what's the purpose of healthcare? And that's as a healthcare provider. I mean, I came to the health department with 32 years of experience in the private sector, taking care of sick folks in West Mississippi, which is a challenge.
Yeah.
And really what drove me to accept the position that I did not want or seek to run the health department was the opportunity, can we do something? And as I looked at our Commonwealth scores being abysmally low for the entire population, what really gets the attention of people I'm speaking to is when I show them where we as a population, white, black, Hispanic, Native American, and Vietnamese all together, the entire population, the white population is underwater too. And we're one of the very few states that our entire population is lower than the national median. And that means we have too many people in Mississippi who are sick, who wind up being disabled, that we lose from the workforce, that impact the economy of the state, not the health economy, but the overall economy of the state in a very negative way. And this is where outcomes in the Delta, bleed into the rest of the state because of the cost to the economy. If you live in Forest County, which is doing well, your economy is still not as good as it would be had our overall health outcomes been better. And that's the purpose of healthcare. So every year, I started last year, it is to do an update on the health of the population, the health of healthcare, and then the health of the health department.
Okay. Yeah, interesting. So where are we improving? Are there some bright spots we can point to and say, yeah, we're actually making progress there?
Absolutely.
Right.
And these are huge wins. So the thing I'm most proud of is that for 5 years in a row, our obesity rates have trended down. Now, I'll tell you, 2-3 years ago, I just said, well, everybody else is getting fatter than we are. But that's not it. Our rates are decreasing.
Okay.
And so we have moved from a solid 50th to 45th. And everybody's saying, well, that's not a big deal. That's a huge deal for our obesity numbers to have improved such that we move up 5 rankings. And that's an important one because it impacts everything else: diabetes, hypertension, stroke, heart attacks, even cancer. Our HIV rates continue to trend down. And even through the pandemic, our TB rates continue to be under good control despite the pandemic, and we are below the national average on tuberculosis. So you don't have to worry about TB because I worry about TB. You can go and live and work and play anywhere in Mississippi and not worry about it because we worry about it and we keep it under control. Our teen pregnancy rates have been trending down. And all of these things factor into our opioid deaths were down. We're one of 5 states who had reduction in opioid deaths by 5%. That's a lot of Mississippians. So when you put all those things together, you start getting the synergistic effect because the number one killer of Mississippians is cardiovascular disease, so stroke and heart attacks. And hypertension, diabetes factor into that. We improved in diabetes. How about that? We went from 50th to 49th, and brother, you better believe I'll take that win. That's another big one. You put obesity and diabetes improvement together, 10 years from now, the next state health officer will be able to brag that cardiovascular deaths are down.
I see.
But it's because what we're doing, and what we're seeing today is what Thomas Dobbs and Mary Currier were working on, 10 years ago, 5 years ago. And now we take that and move forward with it. So the fact that we're improving those areas, I am preaching if we can do it here, we can do it in maternal infant death. That's an easy one. It's so frustratingly easy, because we don't have to save 3,000 babies. It's more like 50 or maybe 60 babies that are dying today.
And almost all of which are avoidable, right?
Absolutely. I tell you, Gerard, the thing that breaks my heart the most as a Mississippian is leading the nation in preventable deaths. That means more of us are dying every day unnecessarily.
Got it.
We can fix that.
Well, if you can hang around, we'll talk some more.
Sure.
We got Dr. Dan Edney, the state health officer, in the Element Well studio. We're coming right. Element Well studio. We're visiting with the state health officer. That's Dr. Dan Edney. So, the good news is we're progressing. We're making some improvements there. So, one piece of data that I guess I always pay some attention to is the fact, the latest, I guess, information shows that 57% of the births in the state of Mississippi are actually covered by Medicaid.
That's right.
And, that doesn't necessarily mean they're not getting good quality health care as part of that process and the delivery process and even during the pregnancy period. But more importantly, just from a long-term impact on the state's economy, you've got a child in general that's being born into a low-income environment when they're born to a mother that's on Medicaid. That's why they're eligible for Medicaid, because they do have a low level of income. And statistically, the fact is that the prospects of them succeeding and achieving their full potential in a situation like that just lower. That's just statistical fact. It doesn't mean that it necessarily is written in stone that that's going to be the outcome. Not whatsoever. There are a lot of situations where a child is born into a low-income environment and they thrive.
Right.
And they rise out of that. And it's incredible, and it's a huge victory. But it's certainly the deck stacked against them typically when that's the case.
Yeah.
And I wonder, Dr. Edney, is this a function of maybe just needing to educate our people more about what's involved in having a child and caring for a child and the expense associated with that if you already have a low income, just as an example?
Absolutely. In public health, everything is about getting as far upstream as you can. The earlier you can intervene in whatever process of generating disease or death, the less it costs and the more effective it is, the higher impact. So, but Gerard, today I am paddling the canoe as hard as I can to keep from going over the waterfall. So getting upstream is a dream for me, but it's the goal. So getting upstream with maternal infant death is education and helping pregnancies be healthier to achieve a better outcome, which means engaging in prenatal care earlier, which means making sure women do not become pregnant and immediately become high risk, as so many of our Medicaid moms are, because of diabetes and hypertension, because they're achieving health coverage by getting pregnant.
Right.
When we really need them to be healthy before they're pregnant and understand what's a high-risk pregnancy. And, yes, you're overweight. That puts you high risk. Do you know if you had what your blood sugar, blood pressure is running? Do you even know? And that when you have a baby, you need to wait 18 months before you have another one if you choose to have another. And we can help you with long-term family planning services with long-acting contraceptives.
Okay. I hadn't thought about that.
All of that is, it's a comprehensive approach to maternal infant health. I'm focusing on death because we need to keep them alive first. But it's not only achieving fewer deaths, is having a healthier population of those who survive. So as we're working on the early intervention program to make it better, that's for our 0 to 3 population that are developmentally delayed. The best way to do that is to protect them from being developmentally delayed by having a healthier pregnancy. Yeah. And so it's all about prenatal engagement. It's all about baseline health for all of us. As the health of younger women of childbearing age is better, our outcomes improve for our babies. Now, the issue of babies needing more is very important. I just had my 5th grandchild. Miss Vivian Edney is healthy and happy most days. She was a high-risk pregnancy.
Okay.
And her mom had to be on blood thinners. And I sweated and prayed that whole pregnancy. But I promise you, I was going to make sure Vivian Edney and her mama had everything they needed to have a good outcome. I firmly believe that it is our obligation to make sure the babies in Tallahatchie County have the same chance. to have the same good outcome. But you and I know it will take more for that baby in Tallahatchie County to have the same chance. I'm just talking about health outcome. I'm not talking about long-term success in life.
Sure.
I'm just for them to be alive at 1 year of age.
Sure.
It's going to take more than it's going to take for Vivian Edney. And so part of my job is to make sure that those babies in Tallahatchie County, Coahoma County, Pike County, Amite, all those babies have the same chance that my grandchildren have to live to be 1 year of age. I don't think that's asking too much.
And because the reality is most of that is avoidable, is preventable,
It
right?
is. But a huge number of our deaths are just from putting babies to sleep on their stomach. So education, as you said, the back to sleep program is really important.
Okay.
But as we get women engaged in prenatal care earlier, as presumptive eligibility is going to help with, then we can begin education earlier. As the science is very clear, the earlier you're engaged in prenatal care, the more likely you are to survive your pregnancy and for your baby to be healthy.
And the good news is it not, Dr. Edney, that the practice of prenatal care is advanced tremendously?
Yes.
Tremendously.
Last baby I delivered was 1988. Thank the Lord. I hadn't had to deliver another one since then. The science is incredibly advanced.
Yeah.
And so part of our job is moving that science into practice.
Yeah.
And we're doing that through our new obstetrical system of care, focusing on those high-risk moms and making sure hospitals are designated at the proper level, what hospitals can handle what level of care, what level of risk, and making sure to the best of everybody's ability that high-risk moms deliver high-risk babies at the right place and the right way at the right time.
I know you and I have talked about this, but I had the privilege, I would call it, of getting a personally guided tour from Dr. Jimmy Keaton of the NICU. UMMC.
It's an amazing place.
It's incredible. It's absolutely incredible. It honestly, it affected me permanently, just that brief exposure.
And you saw the babies there.
I saw the babies there.
Now, if that baby is born in a lower level birthing hospital, we have to transport that baby to Jackson.
Yeah.
That baby is at risk the whole time. We need that baby born in centers like that if they're very high risk.
Yeah.
If we can. We can't always do that. And so it's our job to make sure the transfer and transportation system facilitates that so that doctors in the Delta who need a transfer, we can make it happen for them.
Well, what really struck me in the conversation with Dr. Keaton, when I asked the question, how many were avoidable, preventable, and he said most was his response. So, I mean, which really comes under your purview is how do we improve that situation and so that these mothers understand the risks when they're getting pregnant, before they get pregnant, if they're planning on starting a family or having another child, and then how do we ensure they get proper prenatal care so they don't end up in the NICU, which is the case often.
Right, and so we at the health department have to work with the right community leaders for the impacted populations to get partners to help us message and to say, all right, you have Medicaid, let's get on to your healthcare provider and start your prenatal care. And FQHCs around the state do an amazing job at engaging in prenatal care and doing education and helping to improve outcomes. What's really literally killing us are the moms who are showing up as they're crowning. They've had no prenatal care.
It's amazing.
They're on Medicaid, but they have not engaged in prenatal care for a list of 15 reasons, and they're delivering a high-risk baby. So our job is to look at those 15 reasons.
And high risk to the mother as well, right?
It kills the mama.
I can tell you just a personal experience. My wife experienced, is it eclampsia, I think?
Yes. Mm-hmm.
And she was on her back for almost 2 months with my second child. And you know the risk associated with that. And as soon as nothing she did or didn't do, it just worked out that way, the way the pregnancy evolved. But what I recall is that once my son, that case, was delivered, all that just immediately cleared up.
Right. And then there's the entity pregnancy-induced hypertension that may or may not clear up.
Okay.
And gestational diabetes related with pregnancy, which may or may not clear up. And that's where 12 months postpartum coverage for Medicaid has been extremely helpful so that we can take those women through those high-risk postpartum months and improve our outcomes. But medical homes are where the answer is, Gerard. The health department is there for public health, but it's getting Mississippians into medical homes so all this can be done.
We can do it, as you said. And Dr. Edney, I just want you to know I appreciate your advocacy and your willingness to speak up, speak out about this, and let's make Mississippi healthier. That's the bottom line.
Let's do it. I appreciate it. Thank you.
Yes, sir. We're coming right back, folks, in the Element Wealth studio. Stay